My name is Marissa Borelli, and my scholarly project, short paper, and presentation is on chronic kidney disease education programs. The prevalence of chronic kidney disease is growing in the United States. According to the National Health and Nutrition Examination Survey, the incidence of CKD has increased from 18.8 to 24.5%. The number of incident cases in 2012 alone was over 110,000. As the glomerular filtration rate declines and the creatinine level increases, the patient progresses through the 5 stages of CKD. In 2009, 871,000 Americans were being treated for end-stage renal disease, according to data from the National Kidney and Urologic Diseases Information Clearinghouse. But in actuality, 44% of patients starting dialysis in 2008 have never been to a nephrologist, and over 80% start with a central venous catheter, which are known to have poorer outcomes. 30% of patients reported insufficient knowledge of the dialysis treatment and were not aware of the various home modalities. These combined factors contribute to the high rates of mortality of up to 30 to 40% within the first 90 days of the dialysis initiation. In an ideal world, patients with diabetes or hypertension at risk for chronic kidney disease would be referred to a nephrologist for renal care. Once stage 4 kidney disease develops, the physician and patient would start planning for the event of renal replacement therapy or preemptive kidney transplant. At this time, the patient and family would be referred to a CKD education program provided by the physician group or the CKD ESRD community. But oftentimes, patients are started on dialysis in an emergent situation in an acute care setting due to issues such as respiratory distress, hypervolemia, or hyperkalemia. Many of these patients are unaware they would require a form of renal replacement therapy and have no understanding of what the disease or treatment entails. When patients are started on dialysis emergently, they often have not had an arteriovenous fistula placed and start with an internal jugular catheter, which, as I mentioned, has a very high chance of infection and contributes to central vein stenosis. So the commonplace that I'm seeing in today's new starts are urgent starts in an acute setting. Patients are starting in the hospital. They're not starting in an outpatient unit. There are a lack of permanent vascular accesses. Patients are starting with catheters. They don't have fistulas or grafts in place. There are not many patients starting on home therapy, and almost all the patients starting in an acute setting are started on in-center hemodialysis versus peritoneal dialysis. Patients are not active participants in their care. They're placed on hemodialysis by default. They have not had the opportunity to choose a treatment modality that supplements their lifestyle. And they lack end-stage renal disease education. The data concludes the necessity of developing a comprehensive CKD education program to those patients nearing ESRD. Such a program will allow for individuals to be educated at a time when they are not in acute distress and they have the ability to make decisions. Participants and their families can be educated on how to slow the progression of renal failure, what to expect with ESRD, and are given the ability to choose a form of treatment modality and vascular access. By giving patients with stage 4 CKD a comprehensive summary of the disease, these patients can be active participants in their care and can adequately plan for their future. The comprehensive education will explain to patients how to manage health conditions and comorbidities. They will be given information on kidney function, The purpose of delaying dialysis, dietary restrictions, the prevention of uremic syndromes, purpose of medications, and treatment option and modality that will best suit their lifestyle. CMS involvement in CKD education program began with the Medicare Improvements for Patients and Providers Act centers, as they have fully acknowledged the need of an educational program to improve patient outcomes. As of 2008, CMS introduced a bill covering kidney disease education for those diagnosed with stage 4 kidney failure. Medicare covers 80% of 6 educational offerings for its Part B beneficiaries. The CKD education can include 1 hour individual face-to-face or 1 hour face-to-face group educational services. The education program must be provided by an MD, PA, NP, or CNS. The program must evaluate the patient's knowledge gain by providing a pre- and post-test. CKD education allows the participants to be an active collaborator in their care with education tailored to meet the individual's needs. These services are billable. The Kidney Disease Education Lecturer Builder is a program that assists educators in developing lesson plans that can be used for individual or group settings. The lessons can be divided into 6 sessions and meet the requirements of the Kidney Disease Education by CMS. Outcomes assessments of knowledge are required for each session, and the education content should progress as follows: understanding kidney disease, managing your kidney disease, what happens when kidney disease gets worse, choices for treating kidney failure, getting ready for treatment, and living with kidney failure. Young and his group of researchers provides a method of education via group meetings and shared medical appointments. In this method, patients will have the opportunity to receive education, socialize, and ask questions. Group visits can include a meeting with a nephrologist, renal nurse, dietitian, social worker, and pharmacist, and discuss the education material through discussion, handouts, and videos. By treating comorbid conditions, slowing the loss of kidney function may be possible. In addition, this allows time for creation of a vascular access and transplant evaluation. The collaborative care model, Healthy Transitions, was developed in October of 2012, so it's a fairly new initiative. This program provides evidence-based education, care coordination, program protocols, innovative information and technology, and methods for self-management. Collaboration amongst the multidisciplinary team is pivotal in the success of this program. Evidence-based protocols were used to ensure consistency in care and allowed for flexibility from the protocol as individual cases arose. The results of the program are substantial: a 12.1% preemptive transplant rate, a 68.1% functioning fistula rate, and a 22.7% catheter rate. 41% of patients started on dialysis in an outpatient setting, and 32.4% of patients started on peritoneal dialysis. This particular program exemplifies the notion that CKD education programs are beneficial and lead to better patient outcomes. There are many positive outcomes of CKD education. One potential outcome from initiating such a program would be an increase in the number of patients starting with a fistula. Fistulas have the lowest chance of infection, and they have the highest adequacy rates. The decrease in the number of patients starting with a central venous catheter would be another outcome of CKD education. As previously mentioned, catheters have a very high infection rate and lead to central vein stenosis. Additionally, an increase in the number of patients starting on home therapy, either peritoneal or home hemodialysis, as home modalities have better outcomes for patients. There are certain metrics that would need to be measured with implementing such a program. One metric would be the incident rate for AV fistulas. So how many patients that are new to dialysis have a fistula versus a central venous catheter? Another outcome from the implementation of such a program would be an increase in the number of patients starting on home therapy. This would be measured as a percentage of patients starting home therapy versus traditional in-center dialysis. Benchmarks and sources of data can be obtained from large dialysis organizations. Currently, there are 3. I would take my data from Dialysis Clinic Inc., the largest LDO, which is nonprofit. The company's made over 200 dialysis facilities within the United States, so they would have a large pool of data. The data collection can include the number of new starts, the percentage of home versus in-center starts, fistula, and catheter rates. Data can be obtained retrospectively and used for benchmarking and to map improvements. To summarize, there are many benefits of CKD education programs. Unfortunately, there is a lack of education programs within the United States. Some of the benefits of implementing such a program would be the lower number of urgent starts, less hospital days during the first month of therapy, which, according to Rocco in 2009, leads to an estimated cost savings of $4,000 per patient. More patients would be prepared to start dialysis, and there would be more patients starting at home. Clinical outcomes will include a higher serum albumin, hemoglobin, better control of mineral metabolism, and a greater fistula rate. There will be a decrease in the catheter rate. Implementation of a CKD educational program is forthcoming and has the potential to produce positive results by engaging patients to become active participants in their care. The transition of care to ESRD is difficult and with a high mortality rate. Therefore, preparing stage 4 CKD patients for this new cycle of their life can have promising results. Thank you for your time.